Good evening. Welcome to the November 13th meeting of the Washington Township Healthcare District Board of Directors. Please join me in the Pledge of Allegiance.
I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Catherine, if you'd call the roll.
Yes. Director Nicholson?
Present.
Director Wallace?
Present.
Director Stewart?
Present.
Director Dennison?
Present.
Director Eben?
Present.
Thank you. Nancy, if you could introduce our speaker.
We have two education sessions tonight, so I'll start by introducing the first. I think the board is familiar with Eric Reel. He is a senior consultant in the executive compensation and governance practice of integrated healthcare strategies. He has over 10 years of healthcare compensation consulting experience. He has assisted hospital boards and compensation committees with executive and director cash compensation, including assessing the reasonableness and the competitiveness of executive compensation, developing salary structures, and designing incentive plans. He has advised a variety of healthcare organizations from small rural hospitals to large multi-state health systems. He's also worked with medical groups and state hospital associations on all aspects of executive compensation. Before joining Integrated Healthcare Strategies, Mr. Reel practiced class action and antitrust law at the St. Paul law firm of Reinhardt and Anderson. He holds a Bachelor of Arts degree from the University of Wisconsin in economics and political science and a Juris Doctorate from Cornell Law. He is an attorney licensed to practice in the state of Minnesota.
Good evening. As she said, I'm here to talk about cash compensation for the CEO. I work at Integrated Healthcare Strategies, which is the leading specialist in executive compensation consulting for not-for-profit healthcare organizations. We have offices in Minneapolis and and Kansas City, and our services include analysis and design of all aspects of executive compensation. We have clients from major healthcare providers, including hospitals, integrated systems, physician groups, and state health and national healthcare associations. So I'm sure you know Washington Township Healthcare District operates Washington Hospital and employs the CEO. The district is governed by a 5-member publicly elected board of directors and is self-funded, receives no parcel or other tax revenue to fund operations. Washington Hospital Health System is a complex integrated delivery system that includes a 389-bed acute care Washington Hospital. Washington Hospital Healthcare System's primary service area encompasses 124 square miles of Alameda County with a population of more than 320,000 residents. As you look at the slide, you can also see the scope information for WHHS, net revenue of $467 million, and 1,758 full-time equivalent employees. Washington Hospital Healthcare System has, as you can see here, many different includes many different aspects of healthcare listed out here. I won't read through all of them. Talk a little bit about best practices. The IRS recommends the following best practices when it comes to executive compensation. Executive compensation should be approved by a board or committee made up entirely of independent directors. The board or committee should use appropriate comparability data to make its decisions. That data should be collected by a reputable third-party consulting firm, and it should represent like jobs and like organizations. The decisions, rationale, and process used by the board or committee must be documented in contemporaneous minutes. We last reviewed the base compensation of the CEO of WHHS back in 2011. We presented a report and recommendations to the board in November of that year. The CEO last got a salary increase in 2011. At her request, the CEO did not receive an increase in 2012. WHHS's compensation philosophy targets the CEO's base salary at around the 65th percentile of a blended peer group made up of both national and regional data, and provides an opportunity to earn an incentive award that will bring total cash to around the 75th percentile of that peer group. In 2008, WHHS set the CEO's base salary at the 65th percentile of the blended peer group following that comp philosophy. Since then, the CEO's base salary has been below the 65th percentile of the peer group. This year, you asked Integrated to assess the competitiveness of the CEO's compensation by comparing market data with the CEO's cash compensation, and provide appropriate suggestions, if necessary, for modifying the compensation program. I'd like to talk a little bit about compensation philosophy and what it should do. Compensation philosophy is an important tool that facilitates effective governance of executive compensation. It supports a business strategy, mission, and culture of an organization. It encourages consistency in compensation decisions and acts as a guide for current and future decision-making on compensation issues. It also promotes regulatory compliance. WHHS should ensure that its compensation program for the CEO rewards good performance, pays competitively with its peers, and treats executives equitably. It also should reflect missions and goals and aid in attracting and retaining talent. The base compensation of WHHS CEO is based on the same compensation philosophy used for all WHHS employees. Consistent with wage parity, WHHS's goal is to pay competitively with the market. Other factors, such as tenure and experience, are also considered when setting the CEO's salary. WHHS's current CEO compensation philosophy positions base salary as follows. In order to take into account both national and regional data, market data is drawn from a blended peer group of California systems and national systems adjusted for the cost of living in Fremont, California. Since executives are hired from a national market, the board decided to include national data. Since salaries in Fremont are higher than the national average, the board decided to adjust the national data and blend it with data from the California peer group. Here we see that the data sources we used in order to provide you with this information. First, we use our own database, which is drawn from we use data from our own database, which includes 400 healthcare systems, 950 hospitals, 25,000 executives, and over 200 positions. We also combined that with data from other consulting firms, including Mercer and Sullivan & Cotter. This slide shows the process we went through in order to come up with this information. First, we reviewed background data on WHHS. Then we compiled data on compensation levels in the two peer groups in the compensation philosophy. Based on the size and complexity, you use the data from the proprietary database that I mentioned earlier. We compared the CEO's salary to the salaries in the peer group and prepared charts showing 25th, median, 75th, and 90th percentile data. And then we prepared this report to present our analysis and conclusions. So here are the numbers. The table on this slide shows on the far left, the current salary of your CEO and compares it with market data at the median, 65th percentile, and the 75th percentile. As you can see here, her current salary is lower than the median salary in the peer group. To be more specific, she's 7% below the peer group median, 17% below the 65th percentile, which is your comp philosophy, and 23% below the 75th. Here is a bar chart which shows the same data in a different format, but I think helps make it clear where things lie. You also wanted us to take a look at the other part of cash compensation, which is incentive compensation, beyond just the base salary. Over 80% of your peers have an incentive program for their CEOs, and we compared your incentive opportunity as a percentage of salary with the market. As you can see, your incentive opportunity is right in line with the market incentive opportunity. So then we compared her total cash, which is a combination of salary and incentive awards, in this table. On the left is her current salary plus the incentive award from last year. And as you can see, not surprisingly, given where the salary comes out, she's also below the median in total cash. but below the median, below the 65th percentile, and the 75th. 4% below the median and 18% below the 75th, which is where your compensation allows her to be placed. Once again, we provide a bar chart which shows the same data, but in a different way. Looking at the healthcare market in general across the country and in your peer group, in 2013, increases for executives in healthcare have increased on average by 3%. From our surveys and from other sources in the healthcare industry, it looks like 3% will also be the increase in 2014. In addition to base salary, WHS's compensation program includes an incentive component that can pay up to a maximum of 40% of base salary. This provides the CEO with an incentive opportunity that can position total cash compensation around the 75th percentile of the peer group. The chart on the following page compares a range of potential incentive awards with the 75th percentile of the blended peer group. What we've done here is shown if a 10%, 20%, 30%, or 40% award was put on top of current salary and how that compares with the 75th percentile of total cash. As you can see, they are all below the 75th percentile. Any questions?
Thank you, Eric. We'll use this information in determining our CEO compensation. Thank you very much.
Thank you.
We'll go on to our next topic.
Our second education session tonight is a virtual tour of our evolving cath lab environment. Vera Tetrovsky is our presenter. She's relatively new at Washington. She received her undergraduate degree from the University of California at Berkeley. She received her master's in science from Harvard University in health policy and management. She was also a research fellow at the London School of Economics. She began her professional career in the British Health Service in the planning department at St. Thomas's, a Florence Nightingale teaching hospital in London. Subsequently, she was the administrator of a hospital in an underserved region of outer London. Prior to coming to Washington, she was the executive director of the Heart and Vascular Institute at El Camino Hospital across the bay. She also launched the cardiovascular service line at Stanford Medical Center. At Washington Hospital as the chief cardiovascular services, she oversees our cath labs, our cardiac surgery program, our non-invasive cardiology and cardiac rehab program. With that, I'd like Vera to begin her presentation.
Thank you, Nancy. Thank you for letting me come today and to present, and thank you even more for making the decision to invest in the innovation, in the renovation of the cath labs. The cath labs are an important part of the treatment options and oftentimes life-saving. There are three objectives for today's presentation. The first is to convey to you a little history about how the cath labs have evolved over the last couple decades. The second is to explain how your recent investment has been a value added to patient care. And the third is to describe some of the new procedures that are being done at Washington and others on the horizon. The cath labs have been for a long time the domain of cardiologists, and the vast majority of patients have been cardiac patients. However, that has changed in the last few years, and cardiac procedures no longer make up the majority of cath lab procedures. We have an increasing diversity of types of procedures. We have peripheral vascular, where we are improving the blood flow in the limbs. We've got interventional radiology, which improves blood flow to important vital internal organs. And we do neurointervention, where we can even dissolve blood clots in the brain. As a result, we've got increasing complexity, and we have increasing acuity, and we have an increase in use of resources. And some of these cases now range, in great amount of time. We've got the diagnostic coronary cases that can take 30, 45 minutes. But we also do electrophysiology, and those cases can take 2 hours. And our complex interventional cases, such as the neurointerventional that I mentioned earlier, can go up to 5 hours. In fact, today it went for 6 hours. And we, a year and a half ago, started doing ablation for arrhythmia, and those too can take somewhere in the neighborhood of 3 to 5 hours. So it's a very different environment than it was even a decade ago. So drilling down into the data, the analysis of data at Washington shows that we have seen a steady decline in cardiac procedures in the cath lab. And we start here with the first quarter of fiscal year 10 all the way through, I've got on the slide there, first quarter of this fiscal year. Now, that is happening nationally, and I'm sure Dr. Nicholson can tell you more than I can, but it has a lot to do with a lot of the pharma that's come out, and also I think patients really taking better care of their heart health, I should add, and I hope we can do more in that direction as well. So what else are we doing? Well, somewhere along the line, the latter part of fiscal year 2010, the non-cardiac procedures exceeded the number of cardiac procedures, and that trend has steadily continued to increase, so that the volume now is the majority, 62%, or 60% roughly, is non-cardiac, and 40% is cardiac. Yet I think there's a continued perception that the cath labs are sort of the cardiac, hub and domain, and that is not the case anymore. And I think that our focus on cardiac procedures and their has represented an operational performance sort of inaccurately, and also not necessarily captured for reporting purposes all our cath lab revenue. So one of the things that you get and then we report on a regular basis is the number of PCI, which are primary coronary intervention, and those used to be the sort of bellwether, if you want, as to how cath labs are doing and the level of activity. However, now you can see that it's 10%. It's a very small percentage. So our report, which by and large has PCI and all other, is not really representing the entire activity of the cath lab. So why is it important to have the correct count? Well, we use that data for a lot of things. One is that we have those various specialists that use the cath lab, and those specialists need support and different types of supplies and different types of equipment. And that's really good news for the patients and residents of the district. They have increased access to specialized care. We've got the services, I think the neuro and the IR in particular, as well as some of the cardiac. It's very unusual to have that range and depth of services in a community hospital. I think we feel very fortunate for that. And as a result, we do have to also look at changing some of our operations. So in the past, emergency for the cath lab was considered basically a heart attack or a stroke. But now we have a whole category of urgent patients that are treated by some of the other specialists, such as a GI bleed, postpartum uterine bleed, pulmonary thrombosis, that have to be treated not necessarily within the 90-minute window that a heart attack patient needs to be treated. However, they do need to be treated the same day. So we do have to look at some of our operational practices. And we have a need for continual planning because there are a number of new developments on the horizon. Internally, we've had 3 categories for classifying procedures and revenue, and basically cardiac, radiology, and other. And I don't know if you're surprised to see radiology on there, but by and large, cath labs developed out of radiology departments. I mean, it's an imaging service by and large. So we, for consistency purpose, have continued to report in this fashion, but I think that there are other better ways that we can categorize cases performed that'll serve us well in the future. And those are these 4 categories that I have been describing in some detail. And as you can see, again, you've got, the vast majority are non, but they do fall into key categories. And you can't look at these categories and assume you know the type of professional necessarily that perform them. Now, that's not to say that anybody else is doing neurointervention besides a neurosurgeon, although the carotid artery is, in fact, sort of an area that can be done by some specialists that are not neuro specialists. But we also have interventional radiologists that are certified and able to perform peripheral procedures. And we also have vascular surgeons who perform other procedures. So I just want you to know that this has to do more with the kind of treatment and not necessarily with a specialist that are performing those treatments. And that's important because we need to understand the type of skill level that our staff has to have, the amount of training. Very unusual, we have to have staff that are trained in all these specialties, and that requires a fair amount of time and investment, and also requires new equipment and a much larger inventory of supplies to meet this range of procedures. So what advances on the horizon? So what are some of the new procedures we're doing here or hope to be doing soon? So, or very exciting developments. So there's the image-guided intervention on the horizon. So right now, the intervention is guided via an image, sort of externally, like an X-ray, if you want, but it's following the flow through the artery. In the future, we will have cameras at the end of those instead, and we'll be able to look inside and actually see inside what those vessels and arteries look like. Be far more accurate and precise, better for patients. Cardiac, we've got biodegradable stents that are here. We should probably see more of that in the future. We've got the mitral clip and the transcatheter aortic valve replacement, known in the industry as TAVR. Those are, I think, game changers. Instead of breaking open the sternum and repairing and replacing valves, we'll now be able to thread them through the femoral artery, or they're actually doing it from the subclavian. In Germany, they are in fact doing more of those than they are doing traditional valve surgery. And the recovery time is phenomenal. So for the TAVR, the average length of stay currently for a valve replacement surgery nationally is 9 days, and right now it's running 4 for the TAVR. And I frankly think that probably is still conservative, as it's being limited to patients who cannot undergo traditional surgery, who are very ill. So that it probably will shrink with time. Then we've got the oncological radioembolization, very exciting, delivering treatment right to the cancer site. In fact, we did one today. It can go into the bone, the liver, kidneys. And in terms of neuro, the intracranial stent deployment, did that today as well, in adjunction to coiling that patient. So anyway, so those are some things that we are doing. It's very exciting. I think that there's lots. And I think that the reason why this development continues is, we are under the same pressure as in industry, which is, smaller, faster, cheaper, and easier. And so in many ways, these really are better developments and truly allow for faster recovery on the patient's time, as well as reduced infection. So our new cath labs, they offer greater capacity. We'll have for the first time 3 inpatient cath labs. Still close to opening the 3rd. We will be able to accommodate, I think, this diversity of procedures better, and we will be more efficient. So we now have a holding area where we can take patients pre and post so they're ready to go, but also we can watch them post-procedure more carefully. We have a biplane room for the first time. I'm going to let the film describe what is a biplane room. Anyway, and then we have room 8, which is our cardiac room currently, and that will continue to serve cardiac. And room 9 is the one that's under construction. We moved the equipment from the outpatient into room 9. But some of the other developments are that we have installed permanently in room 9 the electrophysiology equipment, which previously was mobile. And that meant that every time we did a case, we had to set it up, which is, quite a bit of time, and take it down. And also, we were always risking. It's very finely tuned equipment. We were jarring it more than we need to. So now this will be permanently installed in room 9, which is much better. And also, we are, putting in the IVUS that can measure the FFR, the fractional flow reserve. Those will be permanently installed in rooms 8 and 9, which means if those tests want to be done, they can be done also more quickly and more easily now that that equipment can be permanently installed. So we don't have to move as much around all the time to be so versatile. We will have more equipment stationary and somewhat specialized rooms. Not entirely, we want to be flexible, but more specialized than we were previously. And with that, we are going to now see what our cath labs really look like. So Joe, take it away.
Washington Hospital's catheterization laboratory is already one of the busiest in the South Bay, and we're happy to announce some significant advancements to the facility that will firmly position our cath lab at the cutting edge of local catheterization services. For the very first time, 3 cath labs are located within the hospital, serving both inpatients and outpatients. An expanded holding area now accommodates 4 beds. And most importantly, we have installed 1 cath lab with biplane technology. Biplane technology employs 2 X-ray sources in conjunction with the latest in digital recording equipment, allowing physicians to obtain higher resolution 3-dimensional images for a much better view of the problem at hand. For example, the new biplane cath lab provides physicians with 2 separate planes of view and a clearer picture with the same dye injection. That means less time is required to complete the procedure and less contrast dye is needed. This state-of-the-art biplane technology will enable the hospital's cardiologist, interventional radiologist, and vascular and neurosurgeons to perform a number of leading-edge procedures with more precision and accuracy than ever before. The new biplane cath lab will result in quicker and more effective procedures for a variety of neurological, carotid artery, kidney, mesenteric, and spinal conditions. Patients' chances of surviving a stroke or brain aneurysm will be greatly improved because neurovascular specialists will be able to locate, access, and treat these conditions without surgery. Physicians will also be able to perform minimally invasive spinal repairs. In short, Washington Hospital's biplane cath lab enables advanced interventional treatment of a wide range of serious problems, faster recovery times, and fewer complications. Washington Hospital is now better poised to respond to continuing innovation that enables treatment to be less invasive and move from the surgical suite to the cath labs.
Our cath lab is very efficient already, but the cath lab holding area gives a much more pleasant experience for the patients. And it allows the cath lab staff to facilitate getting patients in and out of the room and scheduling cases more efficiently.
Now with 3 labs, we have almost got a 100% guarantee of taking the patient straight from the emergency room into the lab and not have to wait around. And hence this will help the patient outcomes. And hopefully the patients in our community will get much better care than what we used to provide before.
If you're planning to do a neurointervention, say coiling of an aneurysm, you may proceed using one plane, navigating your arterial anatomy until you get to the target. But when you have a biplane system, you're able to check the actual anatomical localization immediately without having to move your detectors to make sure that you're not in front of or behind the actual target. That cuts your anesthesia time, cuts the time of the procedure, and makes the procedure actually safer.
With the more advanced technology and programming, I'm able to sort of push boundaries a little bit more because I can see things a little bit better with the better imaging. I think the name of the game is minimally invasive therapies. The less invasive you are, the better the outcome might be. And being able to do these procedures in the angiographic suite, especially the more advanced ones, I think will allow us to improve patient outcome, their stay, their comfort, and their recovery.
Right. So, in summary, PCIs are no longer going to be the bellwether indicator for the activity of the cath labs, and beginning in January of 2014, there will be more detail regarding the procedure count so that we can accurately portray the volume and efficiency. And those categories are going to be aligned with specialty service lines. And the newly constructed cath lab suite will continue to allow for growth and development of procedures for various specialties. I do want to add that we do have to somewhat rebuild some of the volume. During the time of construction, we had very limited access. We had the one room inside the hospital, and people really want to do practice here, and so it was a very busy time, and physicians showed a lot of patients most of the time. So it will take a little while to get some of the physicians to bring more of their cases back as they had taken them elsewhere because they had to get done. So I just want to sort of put that out there. Anyway, we are having an open house December 5th, to which you are all invited, and hope you'll come and you can see for yourselves. So thank you. Question?
Questions from the board? Thank you, Vera. It's really exciting to have these new labs open and ready for use, and I know our physician staff will use them well. So thanks again for showing the board this. Let's move on to our next agenda item, which is consideration of the minutes from October 9, 21, 23, and 28. Do I have a motion? From a motion from Dr. Stewart, and do we have a second?
Second.
Second from Director Danielson. All in favor?
Aye.
Aye. Any opposed? Motion passes. We'll go to oral communications. Any members of the public who wish to speak before the board? Catherine, did we receive any cards? Okay, very good. All right, we'll move on to credentialing action items from Dr. Lenny.
We have two new appointments this month. Dr. Rakesh Patel from Radiation Oncology and Dr. Philip Young, Internal Medicine. The following physicians are up for 2-year reappointments. Dr. Rajiv Ahuja, Internal Medicine. Dr. Rupal Badani, Pediatrics. Dr. Sangeeta Balakrishnan, Cardiology. Dr. David Burke, Cardiology. Dr. William Busby, Emergency Medicine. Dr. Joan Chen, Anesthesiology. Dr. David Cheng, Hematology Oncology. Dr. William Clausen, Pain Management. Dr. William Degoni, Surgery. Dr. David Gorsulowski, Dermatology. Dr. John Yako, Pathology. Dr. Warren Johnson, Podiatry. Dr. Michael Klein, Teleradiology. Dr. Thomas Lee, Teleradiology. Dr. Anmal Mahal, Gastroenterology. Dr. William Paik, Teleradiology. Dr. Marco Pavesi, Pulmonology. Dr. Clifford Popple, Anesthesiology. Joseph Rial, Physician Assistant. Dr. Marilee Schuhard, Pain Management. Dr. Simon Siddiq, Internal Medicine. Dr. Saif Siddiqui, Teleradiology. And Dr. Raymond Silva, Cardiothoracic Surgery. Dr. Scott Kramer is up for reappointment with condition for 1 year. Non-reappointments deemed to have resigned: Dr. Teresa Jensen, who was an OB hospitalist. Advancement or transfer in staff category: Dr. David Burke, Cardiology, will be going from active to ambulatory status. Dr. Rupal Badani, Pediatrician, will also be going from active to ambulatory status. And Dr. William Clausen, anesthesiology and pain management, will go from active to ambulatory status. Dr. Leif Erickson from emergency medicine is going from provisional active to active after completing his proctorship. Dr. Nancy Salama, family medicine, going from provisional ambulatory to ambulatory. Completion of proctorship, Robert Mandenberg in emergency medicine has completed his proctorship successfully. Completion of proctorship in provisional category, Dr. Katerina Guzman, internal medicine, going from provisional active to active. And Li Jiang, physician assistant, has also completed proctorship in provisional category. Extension of proctorship in provisional category, Dr. Richard Wright from otolaryngology, Dr. Ramesh Viragandam, cardiothoracic surgeon, and Dr. Murali Dharan, cardiothoracic surgery. And we have 4 resignations: Dr. Alita Jacob, dermatology; Dr. Barbara Newman, OB hospitalist; Dr. John Cecil Walks, cardiothoracic surgery; and Dr. Khalil Zara, interventional radiology.
Thank you very much, Dr. Lenny. Could I entertain a motion for so moved? And from Director Wallace, and a second?
Second.
Second from Director Danielson. This is for the credentialing action items approval. All in favor? Aye. Any opposed? Motion passes. Gail, you're substituting.
Yes. I'm Gail Tomita. I'm first vice president from the Service League, and I'm here to give Jeannie's report tonight. On Tuesday, November 5th, the East Bay Council of Hospital Volunteers had an informational meeting with Deborah Austin of John Muir, Health Director of Patient Relations and Accreditation, on the topic of HCAHPS, which is the Hospital Consumer Assessment of Healthcare Providers and Systems, and the role of the volunteers. As volunteers, we need to be informed about changes that will affect our hospitals and how we can be an effective member. Several of the board members, as well as a past president, attended this meeting. Our gift shop held its annual holiday gift show on November 7th and 8th. I'd like to thank all of the hospital staff and friends for attending. It was a very successful event because of everyone's support. I invite you to visit the gift shop to see the great gifts and decorations to help make your holiday special. Upcoming is our $5 masquerade jewelry sale, which will be held November 25th, 26th, and 27th. The hours are going to be 7 to 6 p.m. on Monday and Tuesday, and 7 to 5 p.m. on Wednesday. Please come by and see all the great selections.
Great, thank you very much, Gail. We'll be there. We'll bring our $5. Lots of them.
Lots of $5.
Right. Medical staff report, Dr. Lenny.
So our medical staff census has gone down slightly to 501 members, 483 of whom are physicians and 18 who are allied health professionals. There are 27 members of the anesthesiology department, 47 in family medicine, 193 medicine, 36 OBGYN, 59 pediatrics, 27 in radiology, and 112 in surgery. We have 45 physicians in the application process, 21 with pre-applications, and 24 with full applications.
Good. Thank you very much, Dr. Lenny. We'll move on to the hospital calendar.
Let's start with Joe's presentation.
Past health promotions and outreach events. On October 10th, Christy Caracappa, Health Insurance Information Service Coordinator, presented Medicare Part D Prescription Drug Plan Update for open enrollment. 54 people attended. Also on October 10th, Christy presented Medicare Updates for 2014. Both of these seminars provided information for Medicare enrollees on changes and updates to Medicare plans for the coming year. 88 people attended. On October 15th, Washington Hospital hosted the 5th annual Think Pink Breast Health Awareness event. Dr. William Dugoni, surgeon, Dr. Mimi Lin, radiologist, and Dr. Vandana Sharma, oncologist, presented at the event. Senator Ellen Corbett presented a certificate of recognition in honor of the 5th annual event. 314 people attended. On October 17th, as part of a Newark Chamber, Nancy Farber, Chief Executive Officer, presented on the Affordable Health Care Act. 90 people attended. On October 22nd, the Washington Center for Wound Healing and Hyperbaric Medicine hosted a community open house. This free event provided an opportunity for the community to tour the facility, meet the staff, and obtain information about the latest techniques to treat non-healing wounds. 40 people attended. On October 26th, Washington Hospital hosted the Children's Health and Safety Fair. This free interactive event provided health and safety information for families. It also featured the popular Teddy Bear Clinic, staffed by Washington Township Medical Foundation pediatricians. The Teddy Bear Clinic allowed children to bring their favorite stuffed animal for a checkup. This event was co-sponsored by Washington Township Medical Foundation and the Washington Hospital Employee Association. Over 200 people attended. On October 30th, Washington Hospital participated in Ohlone College's Passport to Wellness event. The event provided an opportunity for students to be exposed to strategies to manage stress and learn coping mechanisms. Nachel Bangle, registered dietitian, presented on Healthy Foods, Healthy Minds. 25 students attended. On November 2nd, from 8 a.m. to 2 p.m., the Washington Center for Wound Healing and Hyperbaric Medicine hosted a foot screening. The clinical team examined feet and provided private, personalized lessons on how to best care for them. This event focused on people with diabetes, those with poor circulation in their feet, or those with neuropathy. 22 people were screened. On November 7th, as part of the Diabetes Matters program, Dr. Archana Bindra, endocrinologist, presented Partnering with Your Doctor to Improve Control. 13 people attended. On November 8th, from 2 to 4 p.m., Dr. John Dearborn, orthopedic surgeon, and Dr. Alexander Saw, orthopedic surgeon, presented Don't Let Hip Pain Run You Down. 34 people attended. On November 11th, as part of the Washington Women's Center Lunch and Learn series, Maggie Villa-Gomez, registered dietitian, presented Healthy Holiday Cookies. 22 people attended. Upcoming health promotions and community outreach events. On November 23rd, from 9 a.m. to 2 p.m., Washington Hospital will host the 5th Annual Diabetes Awareness Health Fair. Dr. Prasad Kata, endocrinologist with Washington Township Medical Foundation, and Dr. Archana Bindra, endocrinologist, will present at the event. On December 3rd, from 6 to 8 p.m., as part of the Stroke Education Series, Dr. Ash Jain, cardiologist, and Doug Van Houten, RN, will present Acute Management of Stroke and Chronic Care and Stroke Rehabilitation. On December 5th, from 7 to 8 p.m., as part of the Diabetes Matters program, Michelle Heading, spiritual care nurse, will present strategies for support, coping with chronic illness during the holidays. The Washington Hospital Healthcare Foundation report. The Washington Hospital Healthcare Foundation held its annual Top Hat Dinner Dance on Saturday, October 12, 2013, in the tent at Washington West. The evening began with a hosted cocktail reception, followed by dinner and dancing. 620 attendees joined the foundation to raise funds for the Community Mammography Program, a service of the Women's Center that underwrites the cost of mammograms for patients without the means to pay for them. Carol Dutra-Vernacci, the president of the foundation, said, "The evening was a great night out, and I am so grateful to all the sponsors and donors who supported this important cause." The gala raised $295,000 for the Community Mammography Program. The Washington Township Healthcare District Board of Directors report. In the past month, district board members represented Washington Township Healthcare District at the Union City State of the City address, sponsored by the Union City Chamber of Commerce on October 15th. The Newark Chamber of Commerce's presentation on the Affordable Care Act, given by Nancy Farber on October 17th. The Tri-City Elder Coalition's Senior Night Out on October 18th, and the retirement celebration for Linda Ashley, outgoing Chief Executive Officer of the Newark Chamber of Commerce on November 8th. Washington Hospital Employee Association, WIA. WIA was busy with many social activities during the month of October, including coordinating a ziplining event in the Santa Cruz Mountains and organizing a pumpkin carving contest for employees. WIA is also in the process of conducting a drive for warmth, collecting blankets, sweaters, coats, mittens, hats, and scarves to be donated to Abode Services, which provides housing and supportive services for the homeless. Donations are being collected in the lobby of the Washington West building and in the cafeteria on the ground floor of the main hospital through November 15th. Washington on Wheels, WOW, Mobile Health Clinic. During the month of October, the Washington on Wheels Mobile Health Clinic, WOW, continued to serve community members at the Fremont Senior Center, the Fremont Family Resource Center, the Silliman Activity Center in Newark, the New Haven Adult School, and the Ruggieri Senior Center in Union City. WOW also provided healthcare services to students and families at Grimmer Elementary School and the Fremont Unified School District main office. WOW provided flu shots to 9 different companies throughout Fremont, Newark, Union City, and Hayward. A total of 510 flu shots were provided. Internet marketing. Washington Hospital's website remains very active. The hospital's Physician Finder section was October's most viewed webpage with 15,960 views. Other active sections include InHealth, Channel 78. During the month of October, Washington Hospital's cable channel 78, InHealth, aired new programming, including a health and wellness program, Sidelined by Back Pain, Get Back into the Game, and the October Board of Directors meeting. In addition, InHealth taped a Washington Women's Center evening lecture series, Get Your Child's Plate in Shape, and a Diabetes Matters program, Seasonal Success for Diabetes Meal Planning. Additional updates. Dr. Albert Brooks, obstetrician gynecologist and Chief of Medical Affairs for Washington Hospital, was invited by the Joint Commission to attend the Physician Leader Forum. Dr. Brooks was identified as a national physician leader and a strong proponent of quality improvement and patient safety. The Physician Leader Forum, which will take place on November 21st, will provide physicians the opportunity to discuss important topics in healthcare quality improvement, patient safety, and hot topics in healthcare. In addition, it will provide an understanding of high reliability principles as applied to healthcare law, including how these are being used to transform care delivery and patient outcomes. For more information on any of the programs mentioned, visit WHHS.com or call 1-800-963-7070.
Congratulations to Al Brooks. I'm very proud of him. Last little bit of our calendar is one of the more important parts, and that's our Employee of the Month for November. Linda Ronaldson has been with us for over 20 years. Early in her career, she worked over at the Birthing Center, I think some of you might remember our freestanding birthing center across the street. Her strong organizational skills stood out when she worked there, and she worked very hard to make sure that everybody paid their bills. When the birthing center closed and we consolidated our maternity services in the main hospital, she became the first manager overseeing Washington medical billing. And she left the hospital for a very brief time, however, was recruited back to work in patient accounting. And she was instrumental in our STAR Go Live success. In the last 2 years, she's been dedicated to the EPIC project, helping us get ready to go. And she took on the hospital billing module. She works very closely with the entire EPIC project team. With Linda's hard work, Washington Hospital is considered one of EPIC's top performers with regard to accounts receivable. She lives in Fremont with her husband, and she's known as Patient Accounting's Martha Stewart. She quilts, she needlepoints, she sews, she makes the best rum cake, she gardens and raises chickens for farm fresh eggs. She's a second-generation Washington Hospital employee. I think some of you might remember her mother, Eloise Ronaldson, who was our Director of Food Nutritional Services for many years. She was head of that department when I came on board in 1984. Over the years, she's been instrumental in the accomplishments of the patient accounting department, and she's somebody who truly does deserve this recognition. I hope you'll join me in congratulating her.
Indeed, we're fortunate to have her. Okay, we'll move on to our quality report. And Nancy, will you reintroduce Barbara?
Oh, I wasn't going to introduce her again, I'm sorry. Barbara is our Chief of Quality, and she's here to present the CMS core measures for the 2014 update.
Evening. So I'm going to talk about what CMS and Joint Commission are going to do in starting January 1st of 2014. Before I begin, just remind you that we have two organizations that we report these core measures to, one being Joint Commission and one being the CMS, which is the Centers of Medicare and Medicaid. You would think that they would be in line with each other since we get deemed status from CMS by having Joint Commission accreditation, but they are not in line with each other throughout the core measures. CMS continues to call these measures core measures, but Joint Commission calls them accountable measures. So they even have a difference in opinion on what they're called. So as you know, currently we have 10 core measure sets. You're familiar with these: AMI, heart failure, pneumonia, SCIP, outpatient surgery, IMM, which are vaccines, stroke, VTE, perinatal, and ED throughput. So in January, they will change somewhat. And one thing that CMS has done is now they've categorized them into different strategy domains. And there are 6 domains, being patient and family engagement, patient safety, care coordination, population and public health, efficient use of healthcare resources, and clinical processes and effectiveness. These seem to be the outcomes of those particular core measures. So let's look at them one by one. AMI. This chart that you have in front of you, first you'll see the measure, and then the specifics around that measure, and then the TJC is the Joint Commission status, and then we have CMS status, and then we have which domain that it's put in front of. Now what I did is I highlighted where they're the same, where Joint Commission agrees with CMS or vice versa. So they both agreed that they are going to retire and or suspend aspirin at arrival. They come to this conclusion based on standard of practice and results from hospitals across the country. So this particular indicator, hospitals are pretty much at 100%, and it's become standard of practice, and they don't feel it's necessary to continue to report it. But if you look down at the rest of the AMI components, Joint Commission is wants us to continue to collect them, where CMS has pretty much suspended them or made them voluntary. There's a financial reason for CMS to do this. It actually costs them money to get this data and aggregate it and report it. So in the indicators that have been around for several years, CMS has now appointed it to a joint commission to take over and have the expense of collecting and reporting the indicator. Heart failure, the discharge instructions, Joint Commission has retired that, and CMS says if we want to report it, it's voluntary. And the other two, CMS has suspended completely. So if you look at it, CMS has suspended heart failure core measure, but Joint Commission wants us to continue to collect two of the components. Pneumonia. There was one there that they agreed on. That's blood cultures performed in the emergency department prior to the initial antibiotic. They both decided that it could either be retired, and we could report it voluntary to CMS if we choose to do so. Joint Commission says we need to continue to report on all of the component, as CMS again has now delegated this to Joint Commission, and they will not be collecting it. The Surgical Care Improvement Project, I kind of highlighted where both of them say collect, so they've stayed together on pretty much on this one. I think it's because it's a newer indicator, and the country's not quite there yet at 100% with this, so we're going to continue to collect that. The only piece of it that they retired was the surgery patients with perioperative temperature management. You know, across the country, we have this under control now. No changes on this section of SCIP. Venous thromboembolism, or VTE, this is a relatively new indicator, so both agencies want us to continue to collect it. So we will report these both to Joint Commission and to CMS. And stroke is relatively, probably the most newest one. That was started in January of this year. So both agencies are requesting us to collect this core measure. Emergency department, the throughput, again, one of the newer indicators, and we will continue to collect both of those. On the vaccinations, they have Joint Commission has suspended the pneumococcal vaccine to be reported. CMS says it's voluntary, but influenza, they both agreed that we need to continue to report that. Perinatal care has 4 new indicators. So the first new one is elective cesarean section. Then we have antenatal steroids, healthcare-associated bloodstream infections in newborns, and exclusive breast milk feeding. So both agencies have agreed that we need to collect and report to them these new indicators. And that's what's new on the horizon. Any questions?
Any questions? No, good. Thank you very much, Barbara. Chris Henry, financial report.
Okay, tonight we will be looking at the results of operations and our financial results for Washington Hospital for September 2013. Moving right into our operating indicators, our average daily census for September was 149.8. We'd expected 167.7. Admissions were 676 off of budget at 933, and our patient days were 536 off budget at 4,495. So we continue to see the low census that we've seen over the last several months. Outpatient observation equivalent days were 246. We had expected 301. A lot of that having to do with, I think, a little bit better control of our observation patients that Barbara's been working on. Average length of stay for the month, 4.79. We'd expected 4.99 in September. Looking at utilization, case mix index for the month came in pretty close to what we expected at 1.531. We had 146 deliveries in September. We had expected 168. So that number's been bouncing around a bit over the last several months. Not a real pattern there. Surgical cases for September came in 7 below budget at 360. That included joint replacement cases that were 1 below budget at 118. We had 16 neurosurgical cases for the month. We'd expected 25. And cardiac surgical cases came in 5 below budget at 9. PTCA procedures for the month came in 4 above budget at 34. Just to kind of tail on what Vera was just discussing, just to give you a sense of that mix, of the total 353 cardiac cath lab procedures we had in the month, those were 32 above the budget, by the way. We had 77 cardiac catheters, 34 PTCAs, and then the vast majority of the rest was the vascular work that Vera was talking about. So there has been a change in the mix in there. Outpatient visits for the month came in 520 below budget at 7,376. And our emergency room visits a bit off of budget at 4,251, but still a high level of activity compared to what we've seen traditionally. Looking at our productivity, our productive FTEs for the month came in 36.1 below budget at 1,265. We had 183.9 non-productive FTEs in September, giving us total FTEs 16.4 below budget at 1,400 and almost 49. FTEs per adjusted occupied bed for September, higher than we expected at 7.18. We were looking for 6.70, so still running a little high on the FTEs. Moving into the financials. As always, we'll look at the presentation that we're required to use by the Governmental Accounting Standards Board. First, total patient revenue for the month came in 7.7% below budget at $163,872,000. Our contractual write-offs for the month were 76.16%, so we end the month with net operating revenue about $2.6 million below budget at $39,310,000. Our operating expenses for the month were $736,000 below budget, leaving us with a total bottom line from an operations standpoint of a loss of $823,000. Non-operating income for the month came in about $1.7 million above budget at $2.846 million. Really, the impact there was a reversal of the unrealized loss we'd been carrying on our investments during the month of $1.7 million. So we end the month with a total bottom line from a GASB perspective about $188,000 below budget at $2,023,000. Take a quick look at our Financial Accounting Standards Board presentation. This is the presentation used by the financial markets. Operating bottom line stays the same with an $823,000 loss. FASB does not recognize our unrealized gain on our investments nor our tax revenue for our general obligation bond service. So we end September with a total bottom line from a FASB perspective with about a $344,000 loss. So are there any questions on September? Okay.
We'll go on to operations. Good.
Preliminary report for October. We saw 1,007 patient admissions, resulting in 4,810 days of care. The average daily census in October was 155, slightly higher than the prior month. The high and low range was 179 down to 127. The budget for October anticipated 1,069 admissions and 5,347 days of care, and an average daily census of 172. We're going to be approximately 10% below what we had budgeted in inpatient days. Our outpatient observation and equivalent days were 243. We'd budgeted 296, and I think some of the measures that Stephanie and Barbara are deploying with respect to observation are beginning to make a difference. The average length of stay for adults and children in October was lower than budgeted. It came in at 4.73. We'd anticipated 5. The preliminary information indicates that the inpatient revenue for the month of October amounted to approximately $127,883,000, compared to a budget estimate of $143,384,000. This amount, 57.5%, was Medicare, including Medicare HMO, and 15.9% was Medi-Cal, including Medi-Cal HMO, for a total of 73.4% in government program revenue. We had budgeted inpatient revenue percentages of 56.1% Medicare-sponsored patients and 16.6% Medi-Cal. So the Medicare came in well over budget, and as I believe the board understands, Medicare does not pay for the cost of care. In terms of births, we had 150 deliveries in October compared to the budget of 171. October's deliveries resulted in 334 baby days. Newborns totaled 150 in the month. In surgery in October, we had 379 surgical cases at the hospital. We had budgeted for 441. This includes cardiac surgical cases that came in 5 below the budget at 9, and joint replacement cases that were 12 below budget at 137. Inpatient surgical activity was below budget by 91 cases, while outpatient surgeries were above budget by 3. 685 cases were seen at the outpatient surgery center, so they have exceeded their budget of 593 for the month. For the month of October, total cases seen in the cath lab were 391 versus a budget of 471. This includes PTCAs that came in 18 below budget at 38, and cardiac catheter procedures that were 47 below budget at 98. Interventional radiology procedures came in 3 above budget at 233. Inpatient cath lab procedures were 3 more than anticipated, while outpatient procedures were 83 less than expected. Come January, we'll be reformatting how we report what goes on in the cath lab pursuant to Vera's presentation tonight, which I thought was excellent. Shows the changing nature of the case mix. And that's an important thing for the board to understand, because none of those cases are reimbursed at the rate of cardiac catheterizations. While we may be getting more of them, they don't amount to the same revenue. Outpatient visits for the month of October, non-emergency outpatient visits were 7,842, 1,130 lower than the budget. Emergency room recorded a total of 4,309 patients, a daily average of 139. They came in 78 above budget. Washington, Warm Springs, Newark, Nakamura, and Ohlone Clinic saw approximately 3,956 patients during October, 0.13% less than the budget, so they're pretty much on target. So the total system emergency room and clinic visits for October are 8,625 compared to a budget of 8,192 visits. Full-time equivalents for the month of October totaled 1,439.9 FTEs. They included 11.6 agency personnel. This was 43.2 lower than the budget of 1,483.1 FTEs. The FTEs per adjusted occupied bed were 6.74. We had budgeted for 6.54, so we have some more downward pressure to come into compliance. Our productive FTEs were below budget by 42.7 for the month. Our non-productive FTEs were below budget by 0.5 of an FTE. In summary, we had 5.8% fewer admissions and 10% fewer inpatient days than anticipated in the budget. Surgical cases were below budget by 62. Cath lab procedures were below budget by 80. Outpatient visits for October were 12.6% below the budget, while ER visits were 1.8% higher than anticipated. Clinic visits for the month were budgeted came in below budget by 5. Total paid FTEs are below budget by 43.2% and below the last 12 months average by 64.1. So we're beginning to shed some of the extra positions we had here for Epic and getting back down to the right size. Inpatient charges for the month were lower than budget by 10.8%. Outpatient charges were lower than budget by 6.9%. Our total hospital charges for October will come in below by around 9.9%, nearly 10. In October, on October 31st, there were 127 days cash on hand. Total days revenue and accounts receivable at October 31st was 67.61. Days revenue and accounts receivable, excluding Medi-Cal, was 54.57. During the month of October, $2,564,000 of charges were approved for charity assistance.
Nancy. At this point, we'll adjourn to closed session. We're going to reconvene to open session and announce that no action was taken in the closed session. And there being no further business before this board tonight, this meeting is adjourned. Thank you.